Solution-focused therapy with families. Solution-focused therapy respects the client's own resources and is directed toward building solutions rather than increasing insight into supposed maladaptive psychological mechanisms. It is optimistic, collaborative, future-oriented, versatile, user-friendly, and often effective. The solution-focused approach focuses on exceptions. In other words, times when the problem was not a problem. It can be used with individuals, couples, and families. We will cover it here in its use with families, and it will also be covered in the next course, which is couple therapy, where we will apply it to couples. So focusing on exceptions is building on the past successes of families, since often families did function differently and more effectively in the past, but forgot about that. So the leading figures of this approach, solution-focused therapy, grew from the work of Steve DeShazer in their work and their colleagues at the Brief Family Therapy Center in Milwaukee, Wisconsin in the 1970s. So this theoretical approach was initially developed by working with families, although it is also used with couples and individuals. The theoretical formulations. The assumptions that form the basis of solution-focused therapy are straightforward and uncomplicated. Therapists prefer to focus on the future where problems can be solved. They contend that therapists do not need to know a great deal about the nature of the problems that bring people to therapy. They reject the notion that problems serve ulterior motives or that people are ambivalent about their problems. They assume that clients, in other words families, really do want to change when they come to therapy, and solution-focused therapists believe in the view that people contain untapped, unconscious resources, and they may only need slight shifts of perspective to release their potential. So they actually are already containing the solution to the problem. Their view of the development of behavior disorders. Solution-focused therapy does not concern itself with speculating about problem formation, the past, and how long and where it comes from. Their conviction is that solutions to the problems are often unrelated to the way the problems developed, and that tracking etiological factors is engaging in problem talk. So the basic rules of solution-focused therapy is the following. If it ain't broke, don't fix it. Don't look at things that's working and don't try to work with that. Once you know what works in the family, let them do more of it. If it doesn't work, don't do it again. Get them to do something different. The goals of therapy. The goal of solution-focused therapy is to resolve presenting complaints by helping clients, the family, do or think something different so as to become more satisfied with their lives or their functioning. They trust clients to reach their own goals, so they are very involved in setting their own goals, what it is that they want to focus on and what it is that they want to change. They believe that people already have the skills to solve their problems, but have lost sight of these abilities because their problems loom so large to them that their strengths are crowded out of the picture. Goals include making simple shifts in thinking, concentrating on what they are already doing that works, expanding their use of resources, and helping the clients begin to shift their language from talking about problems to talking about solutions. So the conditions for behavioral change. The task of solution-focused therapy is to help clients amplify exceptions to their problems. In other words, focus on times when the problem did not exist. Effective solutions of which they are already in possession can be unearthed in this way. The therapist strives to work from the client's understanding of the problem and seeks behavioral change. So it's important to find out how they define the problem. So let's look at the core components of solution-focused therapy. Assessment. It does not concern itself with how problems developed, but rather seeks to identify those patterns of behavior that existed when the problem was not operative. Assessing future goals are more important than assessing where problems come from. So assessment from this approach looks completely different than several of the other approaches. Core components 2. Let's look at first session questions that will typically ask by the therapist to the family. What do you think the problem is now? How will you know when the problem is solved? How will you know you don't have to come here anymore? What will the signs be? What will have to be different for that to happen in terms of your behavior, thoughts, and feelings? What will you notice that is different about others involved in the situation? What is your wildest fantasy about what you want to have happen? So how will it look if the functioning is healthy, perfect, and not present? Core components 3. Therapeutic techniques used by the therapist. Interventions are delivered in a 3-step process. The therapist, firstly, actively reframes the problem in a more positive, functional light and compliments the clients, the family members, on their perseverance and resourcefulness up to that point. Secondly, clarifies the logical bind clients have created for themselves, how they act together to keep the problem in place. And thirdly, links a hypnotic-like directive to an inevitable sign of progress. Core components 4. Important terms. One term is customer. The Chasser's term for a client who not only complains about a problem, the complainant, but is motivated to resolve it. He saw that person as a customer. Exception. The Chasser's term for times when a client is temporarily free from the problem. May have been in the past, and we look at what was the exception to the problem. So solution-focused therapists focus on exceptions when the problem did not exist to help clients build on successful problem-solving skills. The formula for the first session task, asking clients at the end of the first session to think about what they do not want to change about their lives as a result of therapy. This focuses them on strengths already available in their lives. In other words, focuses them on exceptions. So you ask them at the end of the first session, before the next session, to think about what they do not want to change about their lives as a result of therapy. What should stay? In other words, what's working? So you leave them thinking about solutions, about exceptions to the problem. Core components 5. You also utilize the miracle question. This is asking clients to imagine how things would be if they woke up tomorrow and their problems were solved. Solution-focused therapists use the miracle question to help clients identify goals and potential solutions. Reframing is another technique. It's a technique of relabeling a family's description of behavior to make it more amenable to therapeutic change. For example, describing someone as lazy rather than depressed. Scaling questions. Clients are asked to rate how much they want to resolve their problems from 1 to 10, how bad the problem is, how much better it is than it was the last time, and so on. And it's used to identify exceptions and break changes into small steps. You can use 1 to 5 or 1 to 10 as the scale. Core components 6. So the focus is on solutions, on what works for the clients. Solution-focused therapy respects the client's own resources and is directed toward building solutions rather than increasing insight into maladaptive psychological mechanisms. It is an approach that is optimistic, collaborative, future-oriented, versatile, user-friendly, and it's often very effective. The task of this type of brief therapy is to help clients to do something different by changing their interactive behavior and or their interpretation of behavior and situations so that the solution a solution to their complaint that they identified can be achieved, according to the Chasser. Core component 7, solution-focused therapists meet clients where they are, so it's present-focused. It often begins by asking clients what brings you in or what are you hoping to accomplish coming here. It avoids the traditional diagnostic categories and preconceived notions of what is healthy, unhealthy, or functional, dysfunctional. It works on what the clients tell you, the family tells you the problem is, and how they define it. Core component 8, the therapist attempts to keep it simple and by taking the patient, the family, seriously. The therapist accepts the client's, the family's version of what is and is not a problem. It is what it is, what they tell you it is. Primacy is given to clients' experiences, their goals, their ideas, their values, motivations, and worldviews, which are respectfully accepted as valid and real. Solution-focused therapy basic rules. We talked about this before. If it ain't broke, don't fix it. Once you know what works, let them do more of it. If it doesn't work, don't do it again. Let them do something different. So, solution-focused therapy goal setting. 1, what will be present when the problem is not there anymore? What will be happening in the family's lives when the complaint is absent? When the pain that brought them to therapy is absent and therefore no longer depict life in the they no longer depict their problem in problematic terms. You get them to clearly tell you how it would be. Goal setting is an ongoing dynamic process. It's open to renegotiation, often more a process of identifying and moving toward possibilities than locking in fixed behavioral targets. So let's look at the miracle question again. The miracle question is asked to elicit goals within an interpersonal framework. So we'll ask them, suppose one night there's a miracle and while you're sleeping, the problem that brought you into therapy is solved. How would you know what would be different when you wake up? So we are careful that clients may take this question as spiritual. It's not a religious question. It's a very practical question. It must be answered in behavioral terms. So what would you notice the next morning that will tell you that there has been a miracle? You know, what will be different in the family? The structure of solution-focused therapy. Work can be done with one person or the whole family. Working with only one of the members present can still have powerful effects. It's typically time limited. There's no preset session maximum, and appointments are made one at a time. One session might be enough. Just a couple sessions, does not need to be a long outdrawn therapeutic process. A course of therapy generally lasts 1 to 10 sessions, sometimes longer, and clients can return on an intermittent or as needed basis. In 1991, research has shown that there was a 4.7 average number of sessions per case. In 1996, it was 3 sessions average per case. So let's look again at the role of the therapist. The therapist serves essentially as a consultant, interviewing purposefully to influence the client's view of the problem in a manner that leads to a solution. So we get them to talk about the future, about solutions, and not dwell on how the problem, how long the problems be, where it come from. We don't focus them forever on the problem. The interview process is directive in that it deliberately encourages clients to look at things differently, but it does not supply answers. Provides clients a context to focus on what is right or being right, or what should be there if things goes right. Our attention as therapists is focused primarily in the here and now, and even more importantly, on the future, since the future is a blank canvas on which the family can paint a picture for future. The therapist assumes a posture of not knowing, allowing the clients to be experts rather than the therapist telling the clients what is really wrong and how to fix it. The therapist forms an alliance with the family. The therapist-family alliance is evolving and dynamic. The therapist needs to assume that the family is also interested in cooperating and consequently to build that therapeutic stance on the assumptions that changing is inevitable rather than difficult. The particular way of cooperating can differ from session to session with the same family who may have unique ways of cooperating. So just again, in solution-focused therapy, they have three categories of looking at people. A visitor, you cannot define a clear complaint or goal. A complainant is the clients present a complaint but are unwilling to take actions. A customer is the person that wants to do something, is willing to reframe the problem in a future-orientated, solution-orientated manner. So solution-focused therapy, questions 1. Questions are intended to build rapport, make space for the family's views, and establish a team. So initial session questions is what brings you here. How can I be helpful? What changes have you noticed since you first made the call to set up the appointment? How do you see the situation? What is your understanding of what would be helpful? What needs to happen here so that when you leave you will think it was good that we went to see the therapist? What can I do that would help that you work better together at getting beyond these troubles and turning your relationship around? So a little bit further about therapy questions. The therapist may make a request that helps direct clients' attention toward exceptions to the problem. Before the second session, between now and the next time we meet, I would like you to observe so that you can describe to me next time what happens in your family life, relationship, that you want to continue to have happen. In other words, working. What is it that you don't want to change? This is a skeleton key question, kind of a generic key question that can fit any lock, but it helps them to shift their perspective between the sessions, to go home and look at what's working rather than what the problem is. It implies that something positive is happening that could be observed and recruit their cooperation. Discussing at the session what was noted can help consolidate and amplify useful new awareness and identify things that is actually working. So let's look at questions intended to identify in operational terms what the clients desire from therapy. So we have goal building questions like the miracle question. What will be different if you wake up tomorrow? If a miracle occurred and the problem is gone. From general to specific, how will you know as a family that you have solved the problems that brought you here, or that you've reached your goals? How will things be different? What will tell you that you are on track to solve the problem? What will that look like? Ends and means questions. How will it make a difference to you as a family when these changes have happened? How will they change the way you feel about each other in the family and your relationship? And then also about the relationship when other members of the family is being more the way you want them to be. What will you see them doing differently that will tell you that there has been change and that it's having a meaningful effect on you? So let's look at questions intended to identify times when the presenting problem has not been present, the so-called exception questions. That includes that search for symptoms of solution instead of symptoms of the problem. When in the past might a problem have happened but didn't, or was less intense or more manageable? When have you managed not to, for instance, argue, fight, ignore each other? What is the difference about those times when the problem does not happen? When in the recent past have you experienced some of the things that you say make a difference, that tell you you're heading in the right direction? When have you noticed that you as a family are doing better with this problem? How have you let the other family members know when they do something that makes a positive difference on you? So now let's look at questions intended to call attention to client self-efficacy when they made changes. So it's called agency or efficacy questions. How did you do that? How did you get that to happen? What was what were you as a family doing differently when you were doing this thing better? How did you as family members decide to do what you did? What would you say you or the other family members need to do to get that to happen more? What needs to happen first? Okay, now let's look at questions intended to acknowledge the difficulty and painfulness of some situations and also to highlight the family's contributions to their resiliency, called coping questions. How have you managed to cope during that time? Given the terrible situation, how bad the problem, argument, fighting has been, how come things are not worse? How did you as a family prevent it from becoming worse? What have you been doing to fight off the problem? How did you know that would help? That's what you did. If you hadn't been through this experience, would you have ever thought you had the strength to go through this? And now let's look at the typical scaling questions where we use numbers from 1 to 10. Scales are used to measure the client's own perceptions on a scale from 1 to 10. How difficult would you say that would be? How severe would you say that problem is? Or if there has been change from scale 1 to 10, how much do you think it has improved? So when you started, the problem was at a 10. Where would you say it's now? 7, 8, 6? So you become very specific in scaling the evaluation of change. So solution-focused therapy and termination. Solution-focused therapy stops when the clients are satisfied that their goals have been adequately met or achieved, or a situation that was identified by their responses to these questions. How can we know when to stop meeting like this? What needs to be different in your life as a result of coming here for you to say that meeting with me was worthwhile? Or what number, 0 to 10, do you need to be in order not to come and talk with me anymore? So the therapist endeavors to become obsolete and thus end therapy as soon as possible. The object is to get clients out of therapy and actively and productively involved in living their lives independently. If you wait until all the problems of the family are solved, you will never end treatment. What is important is to keep in mind that empowering them means equipping them with the tools to solve their own problems as far as possible. You don't give them fish, you teach them how to fish. When they can do it on their own, they need to know when to ask for help and where to go for help, to you. Termination can occur when you are confident that they will know when and where to go seek help, and not when you are confident that they will never have problems again.